We're ready. Well, first of all, I want to thank everyone for being here. I want to thank Vision Expo and the Vision Council for inviting us to participate. My name is Dr. Cheryl Reynolds, and I'm the past president of the National Optometric Association. And our discussion today is really talking about innovation in eye care and how those innovations can help to address the racial disparities that is present in the healthcare system and in the eye care system as well. One of the things that we learned with COVID-19, the pandemic of 2020, is that the racial disparities in healthcare, eye care truly exist, and it's a really big gap. And the National Optometric Association, an organization that was started in 1969, was started to address the racial disparities in vision care, the lack of access to vision and eye health care in urban communities, underserved communities. And so for over those 50 years, we've had doctors, minority doctors throughout the United States that have been focused on really serving populations of patients that definitely need eye care. And one of the things that we've learned in the last few years, especially now in 2022, is that we have new devices that we can detect eye disease earlier with. We have new treatment modalities that we can treat eye diseases such as age-related macular degeneration, diabetic retinopathy, and other complications from diabetes, including diabetic maculopathy, with, and we can prevent vision-threatening complications and loss of vision from these diseases. So I'm just going to spend a few minutes talking about how these innovations can really address some of the racial disparities in eye care and health care. Who are we again? We are the National Optometric Association. Our mission is truly advancing the visual health of minority population. And as I've said earlier, we're an organization that was started in 1969. So for over 50 years, we have truly been addressing this concern. I like this quote. This quote really really kind of summarize the issues because again, the pandemic of COVID-19 2020 really just opened the light, really highlighted that we haven't moved far as a nation, the United States of America, in treating all patients equally. And Martin Luther King said this in 1968, of all the forms of inequality, injustice in healthcare, and eye care, I would add, is the most shocking and the most inhumane. Now, there is a lot of reasons why there are inequality in access in healthcare. But before I address those reasons, I just want to talk about eye diseases. We've heard other companies come up and talk about their innovations. We talk about earlier detection of eye diseases. But a lot of these innovations sometimes don't reach the patients that truly need the early detection. When we talk about eye disease, we can't help but talk about diabetes and its related complication, diabetic retinopathy, maculopathy. Recently, in 2022, January of 2022, the National Statistic Diabetes Report came out. 133 million people now have diabetes. That's up from 2 years ago by 11 million people. And the reason that the numbers are growing and exploding is because of COVID-19, A. B, lack of access to health care. In fact, during the pandemic, most of you already know that the individuals that suffered disproportionately, that had poor outcome, and unfortunately may have died from the disease, were those individuals that had comorbidities such as diabetes, high blood pressure, and other underlying health problems. And the other thing that we know for a fact is that a lot of these patients were minorities. African American Black population, the Hispanic Latinx population. These are the individuals that disproportionately had poor outcome from COVID-19. And when we look at why these individuals had poor outcome, the dimensions of inequality has to do with access to healthcare, access to innovation and the use of innovation for the early detection of eye disease, so testing, treatment, health outcomes, lack of racial and ethnic testing data. A lot of times research is being done, but a lot of times the participants don't look like the population of patients that we serve. Also, to the ability to socially distance. A lot of time, our minority population of patients were the frontline workers. Those were the individuals that, when the height of the pandemic started, they were at work serving the communities. Housing and other social determinants of health, we'll go over that in just a few minutes. And then, unfortunately, the narrative is still there. We have a nation where racism and discrimination still exists. We have a nation where economic access is still there. And even if you are a minority patient or a minority individual and you have income and wealth, you may have not have access to health care. When you look at someone like Beyonce, someone like Serena Williams, who had health care complications during pregnancy, we can see the disparities that exist in maternal health care. Again, those social determinants of health I may have touched on earlier, neighborhood and environment, healthcare. One of the things that we realized with the pandemic is a lot of minority patients lost their insurance. When it comes to losing jobs, a lot of them lost their jobs and those jobs had insurance. So we saw a lot of minority patients without insurance. They couldn't have access to health care. And, of course, education. Again, you can be very educated. It's not the education, it's who's in the chair. And a lot of times those individuals are being judged as soon as they walk into the room as by the color of their skin as opposed to, who that patient truly is. Other things that have really led to some of the inequalities in healthcare and vision care is just trust in the healthcare system. A lot of times my patients that I see sometimes may not believe if I say they have glaucoma. And we know that we can prevent blindness from glaucoma with early intervention and with the innovations that are out there and with the new treatments that are out there. And so we still have to work around patients' lack of trust in the healthcare system. I already mentioned this, limited healthcare access. Minority patients may not have the transportation, childcare. A lot of what's new, you have these at-home testing device, 4C Home for AMD, and now we may have 4C Home for OCT testing. That would really help to help narrow the gap between healthcare disparities. The American Diabetes Association truly recommend telehealth screening for patients that have diabetes for earlier detection of patients' ocular health so that they can get the intervention and treatment that is needed. Cultural differences between patients. A lot of times patients don't believe that their disease can lead to visual complication. You have a lot of patients who have diabetes that don't truly understand their disease. These are the new data that I went over. I talked about diabetes, but it's not just diabetes. Look at blood pressure. Currently in 2022, 160 million people are impacted from hypertension. The new hypertension guideline, before it was 140 over 90. If your blood pressure was 140 over 90 or higher, you had high blood pressure. Not today. The new definition is 130 over 80. Before 130 over 80, you can still eat your bags of potato chips. Now at 130 over 80, you are being treated with hypertensive medication. So we're intervening earlier to prevent complication. And of course, a lot of these patients, as I said earlier, succumb to COVID-19 if they have comorbidities such as high blood pressure and diabetes. For me, as an eye care practitioner, I deal a lot with the retina. So I am in charge of our retina service, and innovation in early detection in retinal disease is something that I'm passionate about. One of the devices that's really awesome and amazing for patients is the optical coherence tomography, and I would hope that most eye care practitioners have an OCT in their office. You can detect changes in the retina before it's even clinically evident. And the other thing that you can also detect with a newer device, which is the OCTA, the optical coherence tomographer, angiography, is vascular changes. Wouldn't you want to have changes in your eyes detected before it's clinically evident? You can intervene earlier, educate the patient earlier, and you can make changes to sort of slow down or delay the progression or onset of the disease. So with OCTA, you can see these vascular changes, the black and white image. You can see the blood vessels that are impacted from diabetes. And the other thing that I like about this innovative eye care device is that I can show the patient what's going on with the blood vessels in their eyes. It's one thing to tell a patient they have diabetes and diabetic retinopathy, but if they see the changes in their eyes, they're more likely to make those steps treatment, intervention, lifestyle changes to really control their disease. The other innovative component that I like in my practice, and I hope that most doctors have in their practice, is wide field imaging. The American Diabetes Association, in their latest recommendation, recommend wide field imaging on all patients that have diabetes. And with wide field imaging, what I like about that is that, again, it doesn't just pick up the changes, the retinal changes in the back of the eye. With wide field imaging, I use that to show the patients their pathology. Again, it's important to let the patient know what's going on in the back of the eyes, but sometimes you have to show the patients the pathology. Once they see it, they're more than likely to believe it. And once they see it and they believe it, they're more than likely to make those lifestyle changes and recommendation. Minority patients tend to have higher A1C values. They're not as well controlled. Data have shown that ethnic groups tend to have higher A1C, typically around 8 or 9. There's a new parameter that really assess their glycemic control that's a little bit better than A1C, and that's called time in range. It's so new, or uh, most of you probably have not heard about it, but nonetheless, if a patient who has an A1C of 8 or an A1C of 9 can see these bleeding spots, these hemorrhages in the back of their eyes, then they understand that this disease impacts their eyes. A lot of times patients will say, I didn't know that I could go blind from diabetes. Yet, diabetes is the leading cause of blindness in working age adults. And unfortunately, for minority patients, African American, Black patients, and Hispanic, there's a higher percentage of patients that have diabetic retinopathy. So there's a higher percentage of that group of individuals that go blind from the disease because, again, they don't understand the disease. So how does innovation help address that? If they understand their disease, they'll take the steps necessary to correct or to delay the onset of further progression by incorporating, whether it's taking the medication as directed by their physician or incorporating lifestyle changes. The other thing that new devices help us with, or new innovative devices, is we can detect stroke in the eyes. And I know most of you guys are eye care practitioners, but a lot of times patients may have a vascular occlusion, which is what these bottom images show, and there's no symptoms. You can be 20/20 and have severe complications in the back of the eye. So I always tell my patients, eyesight is important, but your eye health is more important. And so it's important for me to always communicate, and it's important for the NOA and all eye care practitioners to communicate that your health of your eyes is not your sight. It's more than just your sight. So we could see signs, early high blood pressure changes in the back of the eyes can predict strokes. So patients that have early vascular changes, if they have those changes, they're more at risk of having a stroke 3 to 5 years out. Wouldn't you want to know that you're at risk for having a stroke just based on an eye exam and a retinal assessment, retinal photography? The other thing that's important with the patient that's rubbing his eyes, been a lot of innovation in dry eyes. You know, I always say that as optometrists or in the profession for over 30 years, we can go from the back of the eyes, AMD. Now we have myopia control, trying to make sure, because we're seeing a lot of patients that have progressive myopia. And so we are, educating our doctors on myopia control to slow it down, not to stop the patient from becoming more nearsighted, but we know that as they become more nearsighted, the risk of complication for pathological myopia, which is what causes vision loss, is significant. But dry eyes, patients that have diabetes have dry eyes, disproportionately have drier eyes than normal. Patients on medication for blood pressure have dry eyes. So more and more patients have dry eyes. You know, this pandemic of 2020, Zoom was not something I was familiar with. I wish I had stocks in Zoom. But the point is that we're Zooming quite a bit. We had eye fatigue and eye complaints. And so in our minority patients, we should be addressing that. We have other devices or new devices, your LipiFlow, your MiboFlow, that can help with ocular surface issues, that can help detect drier eyes earlier. We have new dry eye treatment that are available. We have a nasal spray that can help with dry eyes. We have biologics that can help with dry eyes. So it's important that we assess the patient's complaint and don't, a lot of times I tell my students, if you don't address it, they're gonna go somewhere else. So we have earlier ways to detect dry eye complaints and problems. So really, innovation has really led to us being able to address healthcare disparity, eye care disparity, and the time is now. We don't want another pandemic to show that we're still in this big gap of having a racial disparity in our eye care and our healthcare field. And I will say that our patient population is constantly evolving. Our patient population is going to be more diverse than ever before. And so I would advocate and encourage all of you to incorporate these innovations that you have in your field in addressing some of those eye care disparities that exist in our patients. And with that, I'm going to take a few questions from the audience. If you have any questions, I'm here. And I could definitely address them. So I want to thank you for your attention, and I hope this was really an educational 30, 20-minute presentation. Are there any questions?
I didn't necessarily hear any relation to nutrition, access to good nutrition and education around nutrition. Is that also part of this?
Thank you. That is a very important question. So the question is nutrition, access to healthier foods. One of the issues that we found with COVID-19 that has been an issue is the food deserts that exist in urban communities, lack of access to quality foods. And we know that nutrition is really important. When we think about age-related macular degeneration with lutein and zeaxanthin and other supplementation, we realize that, based on the ARED study, that if you take vitamins, those supplementation, you can decrease your risk of getting progressive AMD by 25%. Well, other studies have looked at these nutritional support in patients that have diabetes, and it has shown the benefit of adding lutein and zeaxanthin and other nutritional support in patients that have diabetes to slow down or delay the progression of diabetic retinopathy. So I do talk to my patient in addition to lifestyle modification. And what I mean by lifestyle modification, the DPP study was a major landmark study. If you just exercise 3 times a week for 30 minutes aerobic exercise, you can delay or the onset of type 2 diabetes. You don't have to be treated with metformin. Currently, we have 96 million people who have prediabetes. These are individuals that are on the highway to diabetes without some lifestyle intervention or a change in nutrition and healthy eating. So one of the things I encourage my patients that have diabetes as well as have high blood pressure and other systemic disease is eating healthy, exercise, right? And if you have a Apple phone or a Fitbit, if you do 20,000 steps for the week, that's exercising 30 minutes for 3 times a week aerobic exercise. So just walking is good enough for patients, as well as encouraging the patients to eat healthy. The other thing I want to mention, I'm not a dietitian. As optometrists, as eye care practitioners, we're part of the healthcare team for patients that have diabetes. And it's important, if they're not well controlled, to encourage these patients to speak to a nutritionist so that they can learn healthier food habits and healthier lifestyle. So that, yes, nutrition is really important. Any other questions?
Thank you so much. This is a really important conversation. I'm going to ask this question based in my prior role. I currently work for the Vision Expo, but prior, I represented my family's eye care practices in the community. I did a lot of community relations. I'm not a clinician, but I worked closely with them at our practices, and I would try to translate these important messages out in the community fairs, visiting schools, just talking to anybody who would listen, that we had an audience for, about the importance of eye care. Do you feel that that type of community outreach on the practice level, whether by a doctor if they have time, opticians or others in the practice, do you feel that that actually moves the needle? And I'm hoping you say yes, because I did spend 7 years doing that. But I was in also like a more densely populated urban area, New York. And I'm wondering if you have any anecdotal evidence or hard evidence as to the efficacy of that type of outreach in urban and also not urban areas.
Thank you for that awesome question. So, I'm part of the National Eye Health Institute Eye Health Program, the NEI, NEHAP program. And one of the conversations that I've had is what the NOA has had for over 15 years. And one of our objective is serve where you go. A lot of times it's lack of access, right? Even in urban communities, transportation. A lot of my patients miss their appointments. During COVID-19, we saw a higher percentage or a higher prevalence of diabetic retinopathy. Why? Patients didn't go to the doctor. They didn't have transportation to the doctor. The reason that we have such a higher prevalence of diabetic retinopathy and its complication in minority communities is access. They live in rural communities. And even if they live in urban communities, just challenges getting from their home to the doctor's office. In South Florida, my challenge is a lot of these patients don't have cars, so they have to take the bus. And they get to the appointment late. And then the doctor may not see them if they get there late. So we really believe the NOA. We really believe in, even for myself, I truly believe in giving back to the community. So I do believe that community health fairs, increasing education and awareness helps definitely for that, but also taking an eye exam to the patient. One of the things that we are proud with the National Optometric Association, we've partnered with VSP over the years to do community outreach and eye exam, and that includes doing eye exam on their mobile eye van and their mobile eye clinic. A lot of these patients may not go to the doctor, but if you take it to them, they'll come to you. I don't have hard evidence, but I will say that in studying this, that evidence does show that doing community screenings, community health fairs are really efficacious and they do help. Because I think one of the issues is what we said earlier. A lot of patients know they have diabetes. They just don't understand that it can cause them to go blind. A lot of patients don't know they have glaucoma unless they have an eye exam. Glaucoma slowly steals you of your vision. We call it the silent thief of vision for a reason. There are no symptoms. You don't feel blurry. You can see 20/20 and have advanced glaucoma. So a lot of these patients say, I see well, I feel fine, and they don't know that they have a potentially blinding disease. But with a vision health outreach initiative, if they have family members, they're more at risk, they're more likely to come in because they are more aware of it with those more hands-on sort of intervention. So yes, I do believe that what your family did by going into the community really helped the community. Any other questions? No? Well, I hope this, I think I'm okay with time. I hope this brief presentation has really been enlightening. Again, my name is Dr. Cheryl Reynolds. I'm past president of the National Optometric Association. I'm also a professor at Nova Southeastern University. I've been doing this for a long time, but I look 25, so I feel good about it, you know? And I am passionate about eye health care in the minority communities because, as I said earlier, there's no reason to lose your sight without, just to lose your sight. And my mantra is that we as an eye care practitioner, we do more than just save sight. We can potentially save the patient's life. So again, I want to thank you for listening. I want to thank you for being here. I'll be around if anyone has any questions for me. And again, thank you.